My name is Dr. Daniel Bruns, and this is my presentation to the North American Spine Society Annual Conference in 2016. The topic is the Presurgical Psychological Evaluation. This is a perspective from medical treatment guidelines and translational science. Hippocrates stated that it is more important to know what sort of person has a disease than to know what sort of disease a person has. So over 2,000 years ago, Hippocrates anticipated the importance of understanding your patient and also the importance of the biopsychosocial model because this is its essence. I want to begin with defining some terms. First of all, the biomechanical view of pain. In this model, physical health and mental health are separate and distinct, and pain is regarded as being either real and biological or not real and in your head. So in this model, when pain is not real, it's attributable either to the fact that some people lie about pain, they're malingering, or others imagine their pain. It's about psychopathology. So in this model, either you have real pain or the person is a crook or a crock. Unfortunately, this model does not have any scientific support. That's not how things work. And the model that has support scientifically is often referred to as a biopsychosocial model, which integrates biological, psychological, and social factors. So if we think about what produces pain, disability, and medical outcome generally, we have biological factors making a contribution, psychological factors, and social factors. And to understand medical outcome, we need to see patients in all three dimensions. I also want to define behavioral variables. That's if we rule out objective tests like imaging, nerve conduction studies, and so on. Behavioral variables refer to what patients think, how they behave, and the social context. I want to think about applying the biopsychosocial model to orthopedic surgery. And I want to begin with a question: how do you decide when to do surgery? So I want to use some cartoons here just to exemplify conversations that happen between physician and patient. And so here you have a patient visiting a surgeon. And the surgeon says, so you have a small herniation at L4, L5 on the MRI. How are you feeling? And the patient says, well, it's a little uncomfortable, but I'm okay. So the physician says, okay, if it gets worse, give me a call. Now let's imagine the very same conversation. So in this case, the physician asks the same question. The MRI shows a small herniation at L4, L5. How do you feel? But this time the patient says, PT doesn't help and the pain is overwhelming. I can't work. So the patient is desperate, and the surgeon responds, well, let's review the surgical options. Now, the question to think about for surgeons is that when surgical decisions are being made, to what degree do you base these decisions on examination and objective test results as opposed to what people say and how they behave? So objective variables versus behavioral variables. There are implications that result from this. So imagine again a conversation between surgeon and patient. And the surgeon says, if the pain gets so bad he can't stand it, come back and I'll do surgery. So the patient says, gah, I can't stand the pain, one more second. The surgeon says, great, now you're ready for surgery. Now what's wrong with that conversation? Now, some of the surgeons I work with at times will say to the patients, If the pain gets so bad you can't cope with it anymore, come back and we'll do surgery. Um, I One of the things I remind them of is that, you're selecting patients for high pain and poor coping. Both of these are risk factors for a poor outcome, based on the research that we have. So if you don't think in terms of the biopsychosocial model, you may unintentionally select patients for surgery at a time when the risk factors are actually higher. So, now let's think about another question. When you perform surgery, how do you know when surgery is successful? This is one of those questions that's actually pretty complicated, as you all know, because there's multiple dimensions that have to be considered. And here's what some of them are. If you look at commonly used variables in RCTs, if we think about a fusion surgery, successful fusion is objective, biological, but for the most part in RCTs, that's not the outcome variable. It's often things like pain, which is a subjective symptom, satisfaction with care, that's also subjective, functioning, that's behavior and usually based on self-report. Reduced opioid use, that's behavior, return to work, behavior, quality of life, subjective impression. And so there are studies recommending core outcome variables, and a lot of these are those variables. And you can see most of them are behavioral in nature. The biopsychosocial paradigm shift involves thinking about patients in 3 dimensions and looking at it this way. To the extent that the decision to perform surgery is based on biological variables and the outcome is determined by biological criteria, surgery is intervening in the biological realm. So there are situations where a patient may have a spinal tumor and may be asymptomatic, but it just needs to come out, and you're operating in the biological realm. But in other cases, the decision to perform surgery is based on behavioral variables, and the outcome is determined by behavioral criteria. In this case, surgery is intervening in the behavioral realm. So a patient who is dissatisfied with the outcome of conservative care, reports pain and functional limitations, low quality of life. In this case, we're intervening in the behavioral realm, and now it's a real paradigm shift to think about surgery as being used as a behavioral treatment, but sometimes it is. So, what is a good outcome? It's puzzling. So, here's a situation where the surgeon and patient are talking, and the surgeon says, X-rays of your fusion look great. Looks like a good outcome. But the patient says, the pain is terrible, and I need morphine. Can you fill out my SSDI forms? So in this case, you have a procedure that was a biological success, but a behavioral failure. Let's try another scenario. Here the physician says, sadly, looking at your MRI, you'll never be able to work in the oil fields again. But the patient says, actually, I'm happy with that. I hated that job. So in this case, we have a biological failure with regard to it didn't produce the results that were desired, but a behavioral success. The patient was happy with it. It's been noted in literature that sometimes outcomes are paradoxical. Now, it's important, I think, when considering surgery or other treatments to think about the end point. What are we trying to accomplish? And to the extent that surgery is intervening in the behavioral realm, the assessment of behavioral variables is extremely important. If we're trying to help a person feel different or behave different, knowing about behavioral variables is important. Another consideration here is pay for performance, which is one of those considerations on the horizon. Under pay for performance, what variables will your payers use to rate your surgical outcome? It's probably behavioral variables like patient satisfaction. Those are much more easily quantified. So I think if the goal for the payer and pay for performance is based on behavioral variables, then attaining to that becomes even more important. To the extent that surgery is being performed as a behavioral intervention, behavioral tests are often better predictors of outcome than biological tests. Let's think of an example. A 35-year-old male patient MRI shows an L4-L5 herniation. The psychoval finds the patient also has a 20-year history of depression with morbid somatic preoccupation. What predicts if this patient will feel satisfied with your care? The MRI or the psychoval? In this case, the psychological findings suggest this is a person who is never going to be happy. They're chronically somatically preoccupied and depressed with negative thoughts. Some people, it's just hard to make them feel happy. So, what do? How can we select patients for surgery? And that's the role of the presurgical psychoval, which is also known as the checkup from the neck up. So when we're assessing patients, there's some patients that have a mood problem. Everything they see is like filtered through these dingy lenses. Everything looks bad. They're not happy with anything. And it's actually mood that colors their perception of outcome, their perception of their lives. Some patients have unrealistic beliefs about rehab. Here this patient says, what I really need, doc, is a constant massage while laying face down on a pizza. So the surgeon says, okay, let's try 12 sessions of vigorous pepperoni therapy. There are patients who have completely unrealistic beliefs about rehabilitation. They want to be 18 again. And those patients will be impossible to please. Now, sometimes you run into a patient and they're just puzzling. Here the doctor says, I've seen a lot of dislocated shoulders, but wow, this guy is strange. There's some patients you walk into a room and you think, boy, there's something strange about this guy. And it's hard to know in a few minutes of conversation to figure out what that is. So one of the ways of trying to figure this out are using various sorts of psychological tests or screening devices. So how good are they? There was a massive study done a number of years ago by Meyer and colleagues. It reviewed 125 meta-analyses, and it looked at the science behind medical tests versus psychological tests. And what it found was that overall within their domains, the science behind them was roughly equivalent. The best medical tests were about equal to the best psychological tests, and so on. In some studies of surgical outcome, psychological tests have shown to be more successful than MRI and other medical variables at predicting lumbar surgery outcome. That's because, as we know before, that in many cases surgical outcome is being assessed behaviorally in terms of reduced pain and reports of better functioning. And again, to the extent that we're trying to assess behavioral outcome variables, behavioral tests do better than biological tests. Because of this, a multitude of medical treatment guidelines now recommend pre-surgical psychovals under various scenarios, including Nafs and quite a number of other professional societies, governments, guidelines, and payers. If you look at the Nafs guidelines for lumbar disc herniation, it says, it is suggested that patients be assessed preoperatively for signs of psychological distress such as somatization and or depression. Patients with signs of psychological distress have worse outcomes. Now, there are other guidelines that have similar recommendations, but some have more detailed recommendations for presurgical psychovals. While the Nafs guidelines say you should eval people, it doesn't say exactly how. But two guidelines, the American College of Occupational Environmental Medicine, which is the national work comp guidelines, and the Colorado Worker Compensation Medical Treatment Guidelines, both have more detailed recommendations about how to perform presurgical psychovals. Now, the Colorado guidelines, even though they were developed in one state, have now been adopted by 4 other states and have influenced other guidelines as well. So, what do guidelines suggest about presurgical psychovals? One of the things that they are beginning to assess or recommend is that assessment should be a 2-tier presurgical psychological evaluation process. Now, I was a co-author of a study in 2009 that reviewed the literature about this and identified that within the literature there seem to be 2 levels of psychosocial risk factors, which can be called primary risks and secondary risks. You can think of them as red flags and yellow flags, and our study has been adopted by some guidelines. So what do we mean by primary and secondary in this context? Primary psychosocial risks for spinal surgery include red flags like a patient who is suicidal, homicidal, psychotic, who comes to appointments intoxicated. These are patients who have severe psychological instability and are so unstable as to really be unable to cooperate well with medical care. And so it's important to stop and reassess what we're doing here before proceeding with elective surgeries. Now, in some cases, like Cauda-Equina syndrome, you have to do surgery anyway, but then manage these primary risk factors afterwards. So a primary psychosocial risk, here the doctor says, so when did your back pain start? And the patient says, right after the aliens implanted me with a radioactive tracking device. Now, that's an actual quote from one of my patients. But if the patient says that, you can't treat that with surgery. There are also secondary psychosocial risks. These are yellow flag risk factors like depression, anxiety, job dissatisfaction, somatization. These are far more common, and in fact, most injured patients have some yellow flag risk factors. What's important is the number of yellow flags that are present. As the number increases, the prognosis becomes worse. So in this case, you have a patient. The physician here says, so you're having a lot of back pain. And the patient says, yeah, I have a lot of back pain. I also have TMJ, fibromyalgia, migraines, and GI pain. And I have problems with anger management and panic attacks. And I probably drink too much sometimes. And did I tell you I hate my job? When you have this many risk factors, the prognosis is guarded. One study found that the presence of 4 or more secondary risk factors increased the presence of psychopathology by a factor of 14 and doubled the risk of failure to return to work after medical treatment. The greater the number of risk factors present, the worse the prognosis. I want to talk about mental health demographics and how it's helpful to understand that with regard to the need for a presurgical psychoval. So based on a National Alliance of Mental Illness, in any given year, about 1 out of 20 adults in America will suffer from severe depression. This is major depression, the kind of condition that can be associated with suicidality. In a given year, 3 out of 100 adults in America will suffer from bipolar disorder. And in a given year, 1 out of 100 adults in America will suffer from psychosis. Now, 1 out of 100 doesn't sound like a lot. Do you have 100 patients? If you have 100 patients, odds are you have one patient who has symptoms of psychosis. I've been involved in a group that has conducted a number of studies on primary risk factors. The reason I got into this is, well, it's been over 20 years ago, I had a patient come into my office firing his pistol. Now this patient was intoxicated, furious, and informed me that he intended to go kill himself, but first he was going to kill his surgeon because he blamed his surgeon for his poor outcome. This was a really sobering event to see a person, face to face in that frame of mind, firing his pistol. I'm lucky he wasn't angry with me. But it was what I call a Columbine moment. Facing a person in the midst of a homicidal rage. And, unfortunately, we live in a violent society, and that happens all too often. And so it was that experience that impressed upon me the importance of doing research on primary risk factors. And over the course of the years, our group has done quite a number of research studies on primary risk. We found 71 patients who thought about killing their physician. We found 60 patients who were thinking about suing their physician. We found 80 patients who had a plan for suicide, 49 who had homicidal ideation, and 62 with suicide-homicide ideation. Now, with all of them, we performed psychovals and showed that we could predict these states of mind through psychometrics. The reason for doing that is I really hate being surprised when it comes to primary risk factors, and being able to assess and predict that is important. I've also been involved in research on secondary risk factors. Now, there have been systematic reviews on this, and also in 2009 we published a review of both empirical and consensus risk factors for poor surgical outcome. We've done other review studies as well, and some of these articles are referenced by the guidelines mentioned above. Now, with regard to secondary risk factors, in a given year, 1 out of 5 adults in America will suffer from some type of mental health problem. And when it comes to patients with chronic pain, remarkably, 85% of patients with chronic pain exhibit at least mild depressive symptoms. So, when it comes to chronic pain, mental health difficulties are extraordinarily common. The reason for identifying behaviorally high-risk patients is that by identifying those patients, we can improve the surgeon's performance and improve outcomes. But identifying these patients is not always easy to do. That's because sometimes patients conceal information. So here we have this very happy patient who says, "I've never used drugs. I've never been sad or angry. And I love puppies. You can trust me with oxycodone." And the physician thinks, this guy sounds amazingly good. But sometimes patients who look amazingly good psychologically are too good to be true. And because of that, most psychological measures, the standardized psychological measures, have validity checks. Is the patient trying to fake good or fake bad, to bias the information they present in one way or the other? There are a number of commonly used psychological tests for presurgical psychovals. I want to mention 3 of them of different types. One is a very short one called the Pain Patient Profile. It's designed for patients with chronic pain. And it assesses 3 important risk factors for chronic pain: depression, anxiety, somatization. And this is what the results look like. And so it results read something like a CBC, where you have a complete blood count, where you have, high range versus low range versus average. This is a straightforward, easily understood assessment of 3 risk factors that are commonly seen in patients with chronic pain. So this is one that is straightforward, easy to understand. On the other hand, you have a very complex measure, an MMPI-2RF. It has over 50 different measures, including 9 different validity scales. This was developed not as a medical test, but as an assessment of general psychopathology. So it's primarily a psychiatric test, but it can be helpful for assessing psychopathology in medical patients as well. The results are complex, but it's among psychologists, it's one of the most used measures for assessing psychopathology and medical malingering. Now, next 5 slides, I have a conflict of interest because I'm a psychological test author, but I want to talk about one of my tests, which has also been mentioned by multiple guidelines. It's called the BHI-2. It's a standardized measure designed for presurgical and physical rehabilitation risk factor assessment, and it's intended for patients with pain and injury. And it summarizes the assessment of about 70 different risk factors. Now, this test assesses primary risk. One of the things that I was thinking about when developing this is that's one of the things I most want to know. Patients who have severe psychopathology who may be dangerous to self and others. Then we have multiple measures of secondary risk, which pertain to presurgical evals, response to rehabilitation, and addictive potential. We have measures of poor coping, catastrophizing, and kinesiophobia, and also a validity measure to see if a patient is biasing their responses, faking good or faking bad. So these are also kind of like the P3. It's arranged kind of like a CBC, where you have an average range and scores can be either high or low. Have a standardized score and percentile ranks and a rating that says average, below average, etc. Now this is an average profile with everything in the center. You can also have an elevated profile, and here we have 4 scales showing elevated secondary risks and also one showing elevated primary risk factors. In this particular profile, the report shows the patient has 6 primary risk factors: auditory hallucination, suicidal ideation, violent ideation, pain level of 10 in 7 body areas, so widespread pain, antisocial tendencies above the 99th percentile, also antagonism towards physicians above the 99th percentile. This would be an extraordinarily difficult patient. The slides end my conflict of interest. What happens when you implement an interdisciplinary biopsychosocial model? Now, I want to talk about a study we performed a few years ago. This study was just recently highlighted by the Federal Department of Labor in documents about ways of reducing disability. Now, this was a large study of 29 million injured workers over 15 years. And it was conducted to assess the financial impact of a legally mandated evidence-based biopsychosocial model that was implemented in the Colorado workers' compensation system. Now, this model mandated pre-surgical psych evals and also psychological treatments as well. This study was attempted because in the late 80s, the Colorado work comp system was suffering from hyper-medical inflation, and they're looking for methods of cost containment while still providing good care. So we were able to gather 15 years of data from 45 states, and we had about 500,000 patients in Colorado over 15 years versus usual care in a nation of about 28.6 million. We used the nation as a control, as no other state passed a law like this that mandated an evidence-based biopsychosocial model for the treatment of injured patients. So the model that was mandated was interdisciplinary. It involved surgery and injections, medications, physical therapies of various sorts, chiropractic, OT, PT, and behavioral medicine, which includes psychological treatments like cognitive behavioral therapy. This model followed medical treatment guidelines that were a best practice model, meaning what is the best treatment for the patient. And the criteria for best treatment was evidence of higher efficacy and also treatments that had lower risk and lower patient burden. So if you start with treatments for which there is good evidence of high efficacy, low risk, and low burden, do that. And again, the idea was to do the best thing for the patient. If we return to our to cartoon characters, it might go something like this. The patient says, "The pain is so bad, doc, I can't cope with it." And the surgeon says, "I'm sad to hear that. I think pain coping therapy would help you a lot. It's called CBT. I want to get another MRI too. If it looks like you may need surgery, then we'll discuss that." So it's trying to think of the best treatment that's the lowest risk, lowest burden, start with that, and then escalating to surgery if they fail other treatments and when surgery is appropriate. So what happens when you implement that type of model? Initially, it was thought that by adding psychologists, it would increase the costs, but here are the actual impact on medical inflation. Over 15 years, in the nation, there is a 202% medical inflation rate, in Colorado, 68% using the biopsychosocial model. If we look at disability costs, blue is a nation, 109% inflation over 15 years, biopsychosocial model, 28%. So almost a 4-to-1 ratio here. We estimated the savings in Colorado in 2007 alone, and estimated that this model produced a savings of $859 million, so just shy of $1 billion, with reduced disability. So, what can we recommend? What I would recommend for you is to think of presurgical psychovals as an integral part of the decision-making process, in the same way you use an MRI or nerve conduction study. If you know your patient, you can make better decisions about the best treatment. I would recommend trying to develop a relationship with a psychologist. You know, there are physicians I work with regularly. I block out time for their patients. I get them in faster and have a faster turnaround. Physicians I don't have a relationship with, I work them in when I can. So I think it would be best to have a relationship with a physician. Also, when you refer the patient, don't say that, we want to see if you're crazy. Then it'll make the whole evaluation very adversarial and unpleasant. But if you tell a patient, I'm referring you for this evaluation because this will help me understand you better and help us identify the best treatment plan for you. So, as with Hippocrates, it's important to know your patient. Conclusions. The biopsychosocial model of pain and recovery from injury has broad scientific support